Hi, this is Dr. Ravi. This session we are going to discuss effects of autonomic drugs on blood pressure and the heart rate. I'm going to explain the effects of drugs using this diagram. The first line indicates the baseline blood pressure, which is normal blood pressure, whereas the second line will indicate the baseline heart rate or normal heart rate. First, let's discuss the effects of sympathetic receptors on the blood pressure and the heart rate. Alpha-1 receptor action. So whenever alpha-1 receptor is activated, that would lead to increase in the blood pressure. So the blood pressure is above the baseline and there is increase in it. This is all because of alpha-1 receptor causes vasoconstriction and thereby increases the peripheral vascular resistance and shoots up the blood pressure. Whereas beta-2 receptors, when they are activated, it causes vasodilatation of the blood vessels, and this vasodilatation of the blood vessels lead to a dip in the blood pressure. So you would see the downward shift of the blood pressure. Whereas beta-1 receptor is predominantly present in the heart, and when they are activated, it would cause increase in the force of contraction, increase in the heart rate, and increase in the conduction. Now it's time to discuss the effects of individual autonomic drugs on blood pressure and the heart rate. The first drug which I would be covering is Nor-epinephrine. The action of Nor-epinephrine is on alpha-1, alpha-2 and beta-1. It does not have any beta-2 action, and that's how it differs from epinephrine. Nor-epinephrine has alpha-1 action but does not have beta-2 action, and that's why Nor-epinephrine is a strong vasoconstrictor and it would shoot up the blood pressure because of the intense vasoconstriction caused by the effect on the alpha-1 receptor. So you would see net increase in the blood pressure. Nor-epinephrine also has beta-1 action. Because of this beta-1 action, it would initially cause increase in the heart rate. But eventually, because of the alpha-1 action, increase in the blood pressure, it would stimulate the baroreceptors and it would cause reflex decrease in the heart rate, or it would cause reflex bradycardia. So the net effect of norepinephrine on blood pressure and heart rate is it would increase the blood pressure and it would cause reflex bradycardia. Next is epinephrine. Epinephrine has action on all the sympathetic receptors including alpha-1, alpha-2, beta-1, beta-2 and beta-3. Epinephrine works on both alpha-1 as well as beta-2 receptors, and that's why the effect of epinephrine on the blood pressure is little complicated. Epinephrine at lower doses, it usually stimulates beta-2 receptors, as beta-2 receptors are more sensitive to epinephrine, and hence you may see a little dip in the blood pressure. So hence you would see the dip in the blood pressure, so below the baseline. And this is all because of the beta-2 action. Now let's move on to the next slide. Epinephrine effect at moderate to high dose. Epinephrine in moderate to high dose, it acts specifically or more on alpha-1 action. So alpha-1 action is more predominant, and because of the alpha-1 action, you would see that epinephrine would cause net increase in the blood pressure. So blood pressure shifts up the baseline. And another thing you should remember is epinephrine also works on the beta-1 receptor. It activates beta-1 receptor, and that's why there would be net increase in the heart rate. And the way epinephrine affects the systolic and diastolic blood pressure is different from the norepinephrine. It would cause increase in the systolic blood pressure, whereas the diastolic pressure won't increase much, and that creates a wide gap between the systolic and diastolic blood pressure. Because of this wide gap, epinephrine is known to increase pulse pressure, and that's why it's known to cause wide pulse pressure. Next, the effect of dopamine. Dopamine acts on 3 receptors predominantly in the cardiovascular system. One is D1, that is dopamine 1 receptor, alpha-1 receptors and beta-1 receptors. What is interesting with dopamine is, again, the effect on the receptors depends on the dose. Dopamine in low dose, its predominant action is on D1 receptors. Now these D1 receptors are predominantly present in the renal blood vessels and mesenteric blood vessels. In this place, dopamine causes vasodilatation, so it would increase the renal blood flow as well as blood flow to the mesenteric area. And because of this vasodilatation, you would find little decrease in the blood pressure, but not significant decrease. It would be just little dip in the blood pressure. Where in moderate dose, the action is predominantly on beta-1 receptors, and that would cause increase in the heart. Whereas moderate to high dose, the predominant action would be on alpha-1 receptors, and because of the alpha-1 receptor action, you know that it would cause vasoconstriction and increase in the blood pressure. As you know, the dopamine is a drug of choice in cardiogenic shock, mainly because it would treat the heart failure by stimulating the beta-1 receptors. It would treat the shock by increasing the blood pressure, and at the same time it will maintain the blood flow to the vital organs like kidney. Next, phenylephrine. Phenylephrine is specific only on the alpha receptors, so it has a more predominant action on alpha-1 and has a minor action on alpha-2 as well. Because of its predominant action on alpha-1 receptors, you would expect that phenylephrine is a strong vasopressor agent, and it would cause intense vasoconstriction and increase in the blood pressure. This intense increase in the blood pressure would cause reflex activation of the baroreceptors, and which would lead to decrease in the heart rate, or it would cause reflex bradycardia. Next, isoproterenol. Isoproterenol or isoprenaline has predominant action only on the beta receptors, so it has no alpha action. It only activates beta-1 and beta-2 receptors. Hence, the effect of isoproterenol on beta-2 receptors would lead to slight decrease in the blood pressure because of the vasodilatation. And whereas isoproterenol also has the beta-1 action, because of this beta-1 action, you would see increase in the heart rate. Next, dobutamine. Dobutamine is very specific to beta-1. That's why it is called as beta-1 selective agonist. Because it is selective to the beta-1, that's why it would cause increase in the heart rate and also, as beta-1 action would cause increased cardiac output, and that's why you may see slight increase in the blood pressure but not much. And that's why dobutamine is mainly used for the treatment of acute heart failure. Next, we are moving to sympathetic blockers. In sympathetic blockers, the first drug we will cover is alpha blockers. Alpha blockers mainly block alpha-1 receptors. As you know, alpha action is vasoconstriction, and once these alpha receptors are blocked, then beta-2 receptors are uninhibited, and that's why you would see predominant beta-2 action. And because of this beta-2 action, you would see fall in blood pressure, and that's why alpha blockers are used in hypertension. And because of the decreased blood pressure, you may find increase in the heart rate, which would be a reflex increase. Next, beta blockers. Beta blockers, they block depending on the types of beta blockers. Like there are beta blockers which could block only beta-1, so they are called as beta-1 selective blockers, and there are beta blockers which would block both, that is beta-1 as well as beta-2 receptors. A beta blocker, as they block beta-1 receptors in the heart, and that would cause decreased cardiac output and as well as decreased renin activity. Because of these two effects, you would see net decrease in the blood pressure, and that's why beta blockers are also used in the treatment of hypertension. And as for the heart is concerned, as it blocks beta-1 in the heart, it would cause net decrease in the heart rate. Now we are moving to the challenging part, that is pre-treatment with autonomic blockers. Once you understand the above concept, now it is easier to understand the effect of pre-treatment with certain autonomic drugs and their effects. Say you gave Nor-epinephrine. Nor-epinephrine would cause increase in the blood pressure. Say you gave alpha blocker at this point. So once you give alpha blocker, it would cause blockade of all the alpha receptors. And because of the blockade of alpha receptors, you would see the beta-2 effect, which is unopposed, and because of the beta-2 effect, you would see that there would be no increase in the blood pressure, or there may be slight decrease in the blood pressure. So here alpha blocker has successfully blocked the effect of norepinephrine, but but the action on the heart is uninhibited, it would cause increase in the heart rate. As for the beta blocker is concerned, initially you would see that increase in the heart rate by the norepinephrine. But if you treat the patient with a beta blocker at this point, then you would not see any increase in the heart rate. So heart rate would be at the baseline because beta blocker has successfully blocked the effect of norepinephrine. Pre-treatment with blockers that's you see is different with epinephrine. Epinephrine would cause net increase in the blood pressure, but when you give an alpha blocker at this point, you know that epinephrine has a beta 2 action as well. So if you block the alpha, you would see predominantly beta 2 action, and because of this beta 2 action, you would see decrease in the blood pressure. And as you've seen that epinephrine was initially causing increase in the blood pressure, but when given alpha blocker, it caused decrease in the blood pressure, and this phenomenon is called as Dale's vasomotor reversal phenomenon. And when you give a beta blocker, you would see that propranolol has blocked the beta 1 action, and that's why you won't see any increase in the heart rate. As you know now that phenylephrine is a very strong vasopressor agent, but when you give an alpha blocker like phenoxybenzamine or prazosin, you won't see any increase in the blood pressure. So before giving alpha blocker, you would see increase in the blood pressure, but when you give alpha blocker, there won't be any increase in the blood pressure. So the blood pressure remains at the baseline. Finally, coming to parasympathetic system, as you know that acetylcholine is the major neurotransmitter in the nervous system, in the parasympathetic nervous system. Acetylcholine exerts its effect on the muscarinic receptors mainly through nitric oxide action. Acetylcholine is known to release nitric oxide, and it would cause a slight decrease in the blood pressure. So whenever you give intravenous acetylcholine, you may not notice much decrease or significant decrease in the blood pressure, but there would be slight decrease because of the nitric oxide. But as for the heart rate is concerned, because of the muscarinic action through the vagus, it would cause decrease in the heart rate. Atropine does not cause much change in the blood pressure, but it's known to cause intense vasodilatation of the cutaneous blood vessels, thereby causes intense flushing. Whereas as for the heart rate is concerned, it blocks the vagus effect on the heart, thereby increasing the heart rate. So this finishes the effects of autonomic drugs on the cardiovascular system. Please keep listening to my more lecture videos, and please subscribe me on the YouTube. Thank you very much.